the Professor Christopher, and he's talk why ERAS matters to the anesthesiologist. And welcome, Professor Christopher.
Oh, thank you very much. And it's my honor to be here with you virtually. And I'd like to thank you and the organizing committee for your very kind invitation. I've been to Abu Dhabi a few times, and I always enjoy coming and visiting your wonderful country. So thank you for having me. I wish I was there in person, actually.
Welcome. Yeah.
So my talk today is going to focus on why ERAS matters to anesthesiology. As we know, it's a multidisciplinary approach to patient care, but sometimes our colleagues are not as enthusiastic as we may be. So I'm going to try to focus on what we can do and why it matters specifically to the anesthesiologists. So my objectives for you today is for you to understand how ERAS protocols have been developed in general and why we have them to benefit patient outcomes.
You need to share your slides, Dr. Christopher.
Oh, I'm
please.
sorry. I thought I did. I thought I was sharing them before. Let me see here. Sorry about that. I thought I was there. Oh yeah, I got to share again. Okay, so here we go. Share. Do you see them?
Ready. Yeah,
Do you see them now?
We can.
Okay, there we go. Okay, so you can see them now, correct?
This is the first one. This is the first slide.
Well, it was my title slide, but that was
Okay, okay, go ahead. Yeah.
Okay, so my objectives for you today are to recite the be able to recite the rationale for why ERAS protocols in general benefit patient outcomes, and specifically talk about anesthesia-related ERAS measures and the impact they have on our outcomes, and as well as reducing complications, and describe other ways that we can potentially have direct improvements in patient length of stay and postoperative complications. So I have no financial disclosures related to this topic. I do chair the American Society of Anesthesiologists section on professional practice. And the reason that is relevant is some of these ERAS protocols actually reduce costs. And our committee, one of my committees, is focused on payment for anesthesiology services in the US. And we advise our leadership as well as we educate our members on economic issues important to the practice of anesthesiology. And where that comes to bear is that, traditionally, at least in the US, physicians were rewarded based upon the amount of work they did. It didn't really matter how good the quality was or the outcomes, but the more you did, the more you got paid. So if a patient had a complication, for example, and they would come back for more surgery, you would get paid more because they needed another anesthetic. Maybe not the best way toward patient care, but that's how people made additional income. And then now, though, we are moving towards more a value-based system of payment. We're seeing that with some of the changes in insurance payment in this country. And the idea is to reduce complications, reduce length of stay, thereby reducing costs, so that as hospitals are paid by one lump payment or a bundled payment model, they can make more money that way by delivering a better value and better outcome for patients. So ERAS has been around for a while. The whole concept started over 20 years ago. A couple of gentlemen there, which you can see them on the screen, met in London at a nutrition symposium and decided to start a collaborative effort to focus on perioperative care. And because they were in a nutrition symposium, that you'll see why a lot of the ERAS protocols do involve nutritional support and a different approach to patient care that does focus on nutrition as well. So, but overall, though, ERAS optimizes perioperative care, I think, most importantly, because they engage the patient. So basically, they tell them, hey, you as the patient can affect your outcome if you do some of these things. And we'll hear about them. Things like stopping smoking, maybe not drinking as much alcohol. And some ERAS protocols involve getting prehabilitation, where the patient starts to exercise and do rehab even before their surgeries. But many of the things that we do in anesthesiology will aim towards mitigating the physiologic stress. Stress is bad on us just in general, but particularly the patient undergoing a surgical procedure, that stress can lead to many untoward outcomes. So basically, we're trying to reduce preventable harm. And in doing so, patients have a better recovery, fewer complications, decreased hospital length of stay, overall decreased costs. And from a hospital standpoint that promotes and supports these efforts, they have improved profitability that they can reinvest into other programs. So how do we develop ERAS protocols in general? Well, they're based upon evidence-based medicine. And before them, people kind of did their own thing, what they thought was best for the patient. Some of those things were studied. Some of them were just people's opinion. But now we have evidence-based medicine. And if there's evidence, that goes into a protocol-based care, so that maybe everybody isn't doing different things, but everybody's a little more standardized. There's still a little leeway, but overall, we want to pick out the things we know will improve patient care and practice those throughout all our department and all of our anesthesiologists. But the other thing it's important that if you embark on an ERAS protocol is determine what your target is. What are you trying to improve? It might be length of stay, it might be extubation time, it might be wound infections, but determine what you're trying to achieve with your targets. Equally important, if not more so, is compliance with the protocol. So you get together with other people, maybe people in other specialties, your surgeons, your nurses, etc. And you come up with ideas on what should be in your protocol, but then you want to make sure you know that people are actually following the protocol. Because if you don't achieve the outcomes and targets that you want to know that maybe the protocol isn't good, or maybe people didn't follow the protocol. So it's important to know which one of those that is in order for you to correct the problem and do better for the future. All of these protocols within ERAS are basically come down to two things that are important. One is, how strong is that recommendation? And as you can see, things that are green are highly recommended. They should be performed. They really show good outcomes. Things that are in yellow, it's suggestible, it's reasonable, maybe not as strongly recommended. And then you have things that are very weak, but should be considered. And then you have things that potentially can be of no benefit, or things that actually can be harmful. So it's important to understand the strength of that recommendation, but then also it's the level or quality of evidence that we have. Clearly, the best thing are randomized controlled trials. It's best to have more than one. It's optimal if you can develop a meta-analysis on high quality randomized controlled trials. Then the next level is moderately strength trials. Maybe they're of moderate quality or don't have quite as many. And then the next level down would be maybe you only have one randomized controlled trial. And finally, the lowest is just expert opinion. So it's important to know for each recommendation, both the strength of the recommendation and the quality of evidence that supports that. So if you look at ERAS strategies, most of them are divided into three buckets, if you will. Preoperative care, intraoperative care, and postoperative care. And all of them are multidisciplinary, so it's not generally something just for anesthesiology. It usually involves the surgeon, involves nursing, it may involve rehabilitation, physical therapy, a multidisciplinary approach to be the most successful. If all of that's working together, then you will realize improving your hospital and patient outcomes. So here's some examples of things that would go into those different buckets. So preoperatively, you might have counseling of the patient. Some protocols involve fluid and carbohydrate loading, and we'll talk about why that might be important. Generally, people are trying to get away from prolonged fasting. They're also very selective in terms of bowel prep, particularly for colorectal patients. Obviously, antibiotic prophylaxis is a no-brainer almost. Also need to consider prophylaxis so patients don't get blood clots, and don't overly sedate them preoperatively, which might have effects into the postoperative period. Intraoperative techniques are things like nerve blocks, short-acting anesthetics so that they come off quickly, the patient can wake up faster and get back to their normal routine. Multimodal analgesia is a very key component so that you're not relying on one drug to take away pain. Prevention of nausea and vomiting so the patient can get back to eating and drinking and feeling normal. Limited use of drains, again, so the patient can start feeling normal. Not too much water or salt because that leads to fluid overload. And maintaining a nice warm patient using warm intraoperative fluids. Postoperatively, again, focused on patient analgesia, so make sure they're comfortable, no nasogastric tubes, preventing nausea and vomiting, again, avoiding salt and water overload, early removal of catheters, early nutrition, and try to stay away from opioids and instead use non-opioid oral analgesics, NSAIDs, and get the patient up and moving around as soon as possible so that you can stimulate their gut and, again, getting them back to feeling normal. So depending on the type of surgery, which you see in this column, there's variable strength of evidence, and the recommendation can be strong or weak depending on which type of surgery. But most of these surgeries are generally consistent with using pre-admission education counseling, prehabbing the patient, stopping smoking, stopping alcohol, avoiding mechanical bowel prep, avoiding preoperative fasting, maybe giving them a little carbohydrate depending on the type of surgery they're going to have, and so on. So some of these apply to all, but some of them are specific as well. So here's a nice slide showing why it's important not to have a lot of fasting and to actually avoid the whole body protein catabolism when patients fast. So that's why a lot of these protocols will feed or carbohydrate load patients ahead of time. It's all because we know an injury or an incision to the patient will send sympathetic nerve impulses to the brain and other areas, causing a release of hormones and cytokines, leading to glycolysis and proteolysis. And then that goes to the liver, and the acute phase is to have a hyperglycemic response, and then you have glucose entering the bloodstream and developing insulin resistance. So we're trying to avoid that by feeding them, decreasing the stress response to surgery, etc. And this shows that no matter what type of surgery you have, all of these ERAS protocols in all these different areas result in decreased hospital length of stay. And for places in which you're paid by the episode of care, decreasing that length of stay means you can keep more money because you're not paying as much to take care of them with nursing, with cafeteria services, just occupying a patient bed. So that's the idea. All of them will decrease their length of stay and have the patient get back to normal. So why does this matter to us? Why don't we just kind of give our anesthetic and not really care? Well, it does matter to us, and we can influence the patient's outcome. So here's a study of enhanced recovery in colorectal surgery. And I have to say, colorectal and orthopedic surgery were probably the early adopters to a multidisciplinary approach to ERAS. But we're going to show here specifically, if you adhere to a protocol, how that actually affects your patient outcome. This group employed preoperative components, and you can see what they were there: pre-op counseling, an anesthesiology consult, carbohydrate loading. There are intraoperative components like keeping them warm, giving antibiotics, employing multimodal analgesics, avoiding post-op nausea and vomiting, and then post-operatively, things you can do as well: get the patients moving, get them drinking as soon as possible after surgery. Notice anesthesiology consultation in the preoperative phase is an important component of this protocol. And I'll talk a little bit about that later and what we're doing here at the Cleveland Clinic in our pre-admission clinic to help in this process and to help improve patient outcomes. So more on that later. So this study that in colorectal patients, basically they looked at the adherence. So how compliant was the team in the recommendations that they all agreed to, that had good evidence and supported a good outcome. As you can see, some areas they were more successful than others. So the green, it shows you the intraoperative components, and those are generally the things that we can control. You can see the compliance by this group for normothomia was very high, pretty good at multimodal analgesia, not so good at using goal-directed fluid therapy as a modern, but they were very good at giving antibiotics and PONV prophylaxis. And then on the top for the preoperative components, you see really good at giving an anesthetic consult. Not so good in the postoperative areas. You can see much less compliance with the protocol they had agreed to. Probably the least compliant is starting solid food first day after surgery. Apologize, I'm above the emergency room. You can hear the ambulance in the background, so sorry about that. So what they showed was, so the last column to the right is when they had the most compliance with the protocol. So more than 75% adherence. As you can see, they had the best impact upon complications, pneumonia, reintubation, ventilation more than 2 days, sepsis, urinary tract infection, pulmonary embolus, and just overall surgical site infection. So the more you adhere to the protocol, the better off the patient did. But they did also have some improvement if they employed some of the measures, but less than 75% of them, but at least you had some cooperation and some improvement. That's that middle column. But the main thing is if they had greater than 75% adherence with all the measures, they had the biggest impact on length of stay. You can see with using less than 75% of the measures in the middle column, they had a little bit of reduction from 10.1 to 8.6, but they had the most reduction in the length of stay, all the way down to 5.7 if they employed more than 75% of the measures they have planned on. So so what can we influence? Let's just say you're working at a place, surgeons don't believe in ERAS. What are things that we can do specifically as anesthesiologists that can influence the process, influence length of stay? And for those who work in America, where where it matters how much money your hospital makes, you can really make a difference in your patient care as well as the finances of the hospital. So this study, and you'll see Michael Grant has done a lot of this work. We'll talk about a couple of his papers throughout this presentation. But he and his team specifically looked at anesthesia influence process measure compliance and how that impacted length of stay. So they used a cohort of colorectal surgical patients. You can see all types of colorectal surgeries, from proctectomies to rectopexies, ileostomies, laparotomies, sigmoidectomies, etc. They looked at only elective cases, so no emergency cases, and they had a 2-year study period. and basically showed how patients did before and after protocol implementation of ERAS. So preoperatively, they gave patients a carbohydrate drink at least 2 hours before surgery, used preoperative multimodal pain medication, acetaminophen, celecoxib. They used gabapentin, although now that's falling out of favor. But they also thought about nerve blocks, either thoracic epidural or transverse abdominis plane blocks. And intraoperatively, they kept the patients warm. I mean, these are almost things that we should be doing all the time anyway. Keeping patients warm, minimizing the anesthetics that may last too long. Like if you have a long surgery, a long inhaled agent might have postoperative effects, as opposed to using propofol as your primary anesthetic, which may have an impact on post-op nausea and vomiting and a more rapid awakening afterwards. And they used both a preoperative scopolamine patch and intraoperative ondansetron. Post-operatively, they kept close watch on their fluid administration, gave them NSAIDs. In other words, they didn't wait until they had pain, but they scheduled non-steroidal anti-inflammatory agents for 48 hours afterwards. And they only gave opioids for breakthrough pain when their non-opioid alternatives were not sufficient. And here's what they showed. So the purpose of this is showing that, maybe you don't do all the measures. Maybe you can't achieve every single measure. They had 9 measures in total. But even if you employ some of them, your hospital length of stay does become reduced. Obviously, the biggest benefit you have is the more measures you employ, the biggest impact you have on length of stay. But you can see they started around 9 days or so, and they got it down to less than 5 days by employing more measures. The more measures that they employed, the bigger impact they had on hospital length of stay. And again, these are just anesthesiology process measures. The point being that we as anesthesiologists ourselves can make a difference in patient outcomes and length of stay. This is another way of showing that. So pre-ERAS is black and ERAS patients are in light gray. Again, showing the more you employ, so a high degree of process measures, more than 4, had the biggest reduction because some of them were employed preoperatively as well. So the more they used, the better the patient did. And in particular, you can see pre-op carbohydrate loading, preoperative pain meds, using Ativa and no inhaled agents, using PONV prophylaxis and post-op non-steroidals, and following an opioid protocol have the biggest impact upon the patient's hospital length of stay. So here's another study that focuses on the economic evaluation. And again, in the US, where healthcare dollars are at a premium, and we're having a high cost of living adjustments here, so it's costing more to take care of patients. It's important that we pay attention to the finances. So here they consider that there's direct costs, so things like being in the hospital, medical expenses, and there's indirect costs for the patient being in the hospital. So they may lose their ability to work, maybe temporarily. And then there's pain and anxiety for the patient and the family. That's an intangible cost, hard to put a dollar figure on that. Then from a hospital standpoint, there's things that are direct costs, like their care, resource consumption, administrative management, and then intangible costs like the labor that's involved in taking care of patients. And then there's a cost to society as well, psychosocial influence and things of that nature. So they looked at all of those and basically showed that the ERAS group had a higher cost actually overall to take care of them, because if you think about it, they're having rehabilitation, maybe using more medications than they would have otherwise, like we talked about with non-steroidals. overall, you're extending more resources to that ERAS group, but you can see here that the control group saves overall because the hospital length of stay is shorter. So they reduced hospital length of stay from 11.4 to 8.9 days. And although the cost per day was higher in the ERAS group, the overall costs were lower. And it also got the patient out of the hospital, which meant you can take care of more patients by bringing another patient into that patient's bed. So they looked at the per patient cost, and there was some savings there. They also looked at the hospital costs, which were a little higher in terms of implementing those protocols. But overall, despite the type of surgery you would have, they had both a decrease in complications, as you can see in the middle column. So whether it was colorectal surgery, pancreas, liver, gastric, gynecologic, or urologic, they had decrease in complications and therefore a decrease in patient costs. So overall, patients have better outcomes and it costs our system less money. Now, the other thing that ERAS protocols can look into is how much opioids are used, how many they're prescribed. And certainly in the US, this has been a big problem with opioid prescriptions. Patients go home with an opioid prescription. The pills may sit around for a period of time, and they wind up in the community. Sometimes they wind up in teenagers' hands and others. But having those medications in the community is not a good thing. So this group looked at a historical perspective and then a year backwards and then a year forward. And they specifically looked at colorectal surgery, 194 patients before they implemented ERAS, 189 after ERAS, but their focus really was on the opioid prescribing by the surgeon upon discharge. And as you can see here, they had plans that impacted opioid prescribing preoperatively, intraoperatively, and postoperatively. And depending on the patient, all patients got Celebrex, and all patients got Celebrex postoperatively as well. The difference was that they were opioid naive or opioid tolerant patients. So the opioid tolerant patients that you can see in the middle section here generally got a little more opioid because they were tolerant, they were used to getting it, rather than the opioid naive, which are the bottom here. So depending on the type of surgery they had, they took different approaches. So laparoscopic surgery, got an epidural or a tap block, ostomy reversal, tap block and Exparel, and then colostomy, ketamine, lidocaine, or lidocaine plus ketamine or an epidural. So they really targeted the approach to the patient and their previous exposure to opioids, as opposed to taking the same approach with all patients. And postoperatively, they also had a relatively targeted approach so that if patients were not tolerating the treatment, they got the acute pain team involved to make some further recommendations. So really, they had a tailored approach to patients. And as a result, they had decreased opioid prescribing from the pre-ERAS period to the post-operative post-ERAS period, certainly intraoperatively. So, the anesthesiologists obviously were very attuned to this, and they knew that patients wouldn't need as much in the intraoperative period. But really, if we're going to have an impact on opioid prescribing, where we really want to impact is postoperatively, or where we send prescriptions home. And unfortunately, they did not see that effect quite as much in the discharge script. So we need to think about that. So we've done some work here at the Cleveland Clinic, and what we've done is try to target a certain group or population. And Eric Chang at one of our OB hospitals in the area here partnered with the pharmacy team to see if we could reduce opioid prescribing as well as utilization in our C-section patients. And here you can see the effects, the different colors there going from left to right, or 3 different hospitals where we do most of our OB. And you can see the oral morphine milligram equivalents going down over a time period from January of 2019 to March of 2022. You can see a general gradual decline there. Intraoperatively, this is our data on the percent of C-section cases that we could do without using intravenous opioids. So you can see the percent of those cases that we did not use intravenous opioids went up over time as we rolled out this program. And then what we really wanted to was to decrease the morphine prescriptions for patients postoperatively, or Percocet or some oral opioids. And as you can see, the percentage of C-section patients that were discharged without an opioid increased at all 3 of those hospitals over that same time period. And if you look at the average oral morphine milligram equivalents over time, you can see a nice general gradual decline over time. Now, this isn't a very prestigious medical journal, the Wall Street Journal, but we were featured. This work that Eric Chang did was featured on one of the front pages here in the Wall Street Journal back in 2019. So really emphasizing the push for giving fewer opioids to new mothers. So nice work there by Eric. Now, I've been around for a little bit of time. I did a cardiac anesthesia fellowship at the University of Pennsylvania a few years ago, a few decades ago now, actually. And this was our cocktail. We gave patients 10 of morphine, 0.4 of scopolamine. Those of you who have gray hair in the audience may also recall those days. Intraoperatively, we would give them 50 cc's of fentanyl, 10 milligrams of midazolam, 20 milligrams of pancuronium, and we didn't even think about extubating them a few hours. The nurses were happy because the patients were asleep and on the ventilator all night long, and next morning is when we thought about waking them up. But then in the mid-90s, people started questioning that approach, and they talked about fast-track recovery, and they targeted the coronary bypass patient as a relatively homogeneous group that perhaps they can make an impact. But when they talked about fast-track recovery, they basically went from 2.5 days in the ICU to 2 days in the ICU. Not a great improvement. Length of stay, a couple of days, but the percentage of discharge within 3 to 5 days, even with fast track, was still less than 50%. So they really had a ways to go. It looked good at the time compared to what we did in the past, but certainly, not by today's standards. So I wanted to share that perspective with you as we talk about ERAS and cardiac surgery, which is probably one of the newer areas. I am a cardiac anesthesiologist, so that's why I thought I would share this with you as well. We do have a couple people from the Cleveland Clinic that were involved in the initial protocol development. Eric Roselli is one of our cardiac surgeons here in Cleveland, and Nick Fletcher is currently now our Institute Chair for Anesthesiology and Critical Care at Cleveland Clinic, London. So he was at St. George's at the time when this ERAS protocol for cardiac surgery was put together. So ERAS for cardiac surgery is relatively new. They just came out with their consensus statement 4 years ago, and it was during a meeting of the American Association for Thoracic Surgeons back in April of 2018. They published their guidelines in 2019. And as you can see, they took an approach of qualifying every recommendation by the strength of evidence, strength of the recommendation, and then the level or quality of evidence for each of the guidelines they recommended. Similarly to the other ERAS protocols, they focus on the preoperative period on things they can do, things like patient education, nutrition, center spirometry, avoiding prolonged fasting, carbohydrate loading, make sure they got antibiotics. Then the intraoperative period using short-acting anesthetics, smaller doses, avoiding those long-acting narcotics that kept patients sleepy for a long period of time. They employed lung protective ventilation, multimodal analgesia, avoided giving patients excessive volume, and obviously made sure they got their antibiotics. Postoperatively, again, the focus on multimodal analgesia, early extubation, early mobilization, getting the patients up, sitting in a chair, center spirometry, early removal of their chest tubes and lines, aggressively treating their post-op nausea and vomiting so they can have oral nutrition and get their bowels moving and get them back to feeling normal. Older patients in particular are at risk of delirium, so targeted measures to prevent delirium are also important. Part of that is screening them preoperatively and knowing who might be at risk, and then managing delirium postoperatively. So this group, again, Michael Grant's group, looked at implementing a ERAS, enhanced recovery program in cardiac surgical patients. And I like this because, you know, they realized that not everybody can employ every measure all at once. And the point is that even if you employ some of these measures, you'll show some improvement over previous. So they collected data prospectively over 10 months, and they took in all patients, whether they were having coronary bypass, aortic valve surgery, mitral valve surgery, tricuspid valve. They took all patients, which makes it very practical and makes you think that, hey, we can employ this in a wide variety of patients. Again, they had a 3-stepwise implementation, pre-anesthesia and intraoperatively. That was probably their easiest thing to implement first. And then they looked at the pre-operative period, which is basically from the time of the surgery consult to surgery. And then finally in the post-operative period, post-surgery to discharge. And these are the measures, just 7 things. And these are things that we can do just from the anesthesia standpoint. Giving them acetaminophen, I'd say plus or minus now on the gabapentin, ketamine intraoperatively, dexmedetomidine, regional nerve blocks, protective lung ventilation, and fully reversing their paralytics. So 7 measures, and we'll see that in the next slide here, they didn't necessarily introduce all measures at the same time. So the graph shows you the different colors, which measures were introduced early on and what proportion of patients. So you can see the purple line is the protective lung ventilation, and they introduced that very early on in most of their patients. The next thing they employed was a ketamine drip. It peaked there a few months afterwards, started to trail off later. And then you can see other measures there. This is acetaminophen, and that's gone up nicely. It took the longest to get them going with dexmedetomidine, but once they got going in the February-March period of time, you can see dexmedetomidine usage was quite high. So, and then reversing their patients, initially very low, but now they're pretty good, reversing their paralytic. So again, the point is, even if you do something, it's better than nothing, and we'll see here the effects of it. So here we're showing here that if they employed 0 to 4 process measures in blue versus 5 to 7 process measures, the percentage of patients that remain intubated hours after surgery. So in the horizontal graph, you have hours after surgery. You can see very few patients are left intubated after 24 to 48 hours. But the ones that have more process measures, 5 to 7 versus 0 to 4, basically get extubated sooner. So even if you just have 5 to 7, half of your patients will be extubated early on. And another way of showing this, this is on the left side. You can see over time the average number of process measures that were used. And then on the right side, you can see the red, darker red means fewer or 0 process measures were used. In the darker green, you have more, up to 7 process measures used. Again, I'm reminding you what the process measures were in the bottom right there. Oh, sorry, let me go back. You can see what the process measures were there on the bottom right. And then you can see the percent of patients extubated in less than 6 hours or intraoperatively. So as more process measures are showing up here in May, lots of dark green, very little dark red, the percent of patients extubated within 6 hours, which is the lighter blue, or intraoperatively, which is the darker blue, increased as more measures were introduced. Again, I mentioned I chaired the Committee on Economics for the American Society of Anesthesiologists, so we're always thinking about the economic impact, and this group looked at the economic impact of enhanced recovery after surgery in a minimally invasive cardiac surgical patients. So they implemented their ERAS protocol in 61 patients, elective minimally invasive either aortic or mitral valve surgery, and then and look to see what their outcomes would be. So here you see the results. So the control groups are in blue, the ERAS groups is green. You can see the biggest impact they had, although they had some impact in the OR in terms of reducing costs. The biggest impact they had was in the ICU, a little bit on the ward, but the most impact they had here was in the ICU. So the overall cost of that whole hospital stay of the ERAS patients versus the non-ERAS patients was basically almost a couple $1,000s. You can see in euros in the right lower right there of your screen. The costs of the ERAS patients were about 1,400 euros, and the control group 2,200 euros. So nice savings per patient of 1,900 euros. And if you have a big heart center, you can imagine that can have a huge economic impact upon your hospital's finances. So one last thing I want to talk about is this anesthesiology consultation, how you could leverage your pre-admission clinic to help drive some of this patient experience and outcomes. So we have value, I think, as anesthesiologists beyond ERAS. Our preoperative assessment, some of the clinics that we have, we actually do the history and physical for the surgeons, and we take ownership of the tests that are ordered. If you leave it up to the surgeons, they'll order more than the patient needs. So if they leave it to us, we reduce waste by ordering fewer tests. And we can optimize their comorbidities, such as blood pressure, anemia, glucose management, and overall maybe improve patients' health through better management of blood pressure and glucose in particular. Now, the ERAS type of things we already talked about, patient experience with pain and post-op nausea and vomiting and reducing their length of stay, that's all nicely tied with ERAS. But I'm going to talk about our value in the preoperative assessment. But overall, put all these things together, we're really enhancing the patient's quality of care while reducing their costs. So this is an example of a printout that we get for each of our patients coming to the main campus Cleveland Clinic. And it's a nice report here that I'll highlight a few things. First of all, we use predictive analytics to have a twin, and we use a database that consists of 250 billion data points. So we put our patient's data into that algorithm, and we're able to find a digital twin and see what happened to that patient in order to predict what's going to happen to our patient that's here before us in the preoperative clinic. So you can see we can get a prediction of their length of stay, and for this particular patient having ear, nose, and throat surgery was a predicted length of stay of 6 days. And then we get a prediction of how likely they are to have an adverse event, whether it's a cardiac event, a pulmonary event, sepsis, stroke, etc. And in this particular patient, you can see the things highlighted in red with an exclamation point are areas of particular risk for this patient, mainly being pulmonary events. So then we can target our preoperative optimization based upon the likely events. This isn't anything new. Other people have described it as having a perioperative medicine model for population health. And the group at Duke also talked about targeting patients where you can have the most value potential. So patients with full onset chronic disease are most likely to benefit. But I would say you need to know which patients are more likely to benefit versus others. Because we have limited resources and you can't do this for everybody, but which patients are going to have the most impact. So certainly those that have this full onset chronic disease, as well as patients that have certain complex diseases, such as our transplant patients, our cancer patients, and those with congenital disease. So once we identify what issue they have, whether it be anemia, diabetes, nutrition, pain, we can then refer them to the appropriate clinic or consultant to help improve their preoperative state. So all of this is designed to head off these problems before surgery so that the surgery can then proceed and reduce your complications after surgery. The other thing that's really important are readmissions. Many payers in the US are not paying if the patient has to come back. They feel that you didn't do your job, so they're not going to pay you for not doing your job. So we like to highlight and target patients who are at increased risk for readmission, and then also identify why they're likely to be readmitted. In this particular patient, it's still that adverse pulmonary events that make them a particular risk for readmission. And the other thing that's important for us to plan and to get patients out of the hospital is to identify patients that are more likely to need care after their hospitalization. So our predictive analytics can also predict that. You can see this patient's risk is 18.8%. And this highlights exactly why those risks are likely to happen. So things like abnormal findings on their lung field, dysphagia, some nervous system problem, it could be a stroke or something like that, will increase the risk of having an adverse event or needing post-operative care, post-discharge care. So the key takeaways from this lecture is that ERAS protocols are employed to use the best practices based on evidence-based medicine. So it's not just certain person's opinion or kind of what they like to do. We use evidence-based medicine to drive the protocols. But it's important that people follow the protocols in order to realize those improved patient outcomes, in order to decrease patient complications and length of stay. The anesthesia care team has a critical role to making sure we adhere to the most important elements of ERAS. But beyond protocols, the anesthesiologist can also have an impact on readmissions through their pre-op evaluation and management of their comorbidities. It's been an honor to spend this time here with you, and thank you for your time and attention.
Okay.